Hello and welcome. I am Dr. Vivek Kaul from the University of Rochester Medical Center, and it gives me great pleasure once again to collaborate with WebMD and Medscape to present this video capsule. This time we have picked the best GI and GI surgery papers from the recently concluded Digestive Disease Week 2023 International Meeting in Chicago. For this edition of the Medscape GI Primary Care video capsule, I thought it would be nice to present a couple of GI surgical papers that have major impact on common GI conditions seen in primary care. This first paper in the GI surgery realm is real-world type 2 diabetes mellitus remission after 14 years of bariatric surgeries in patients with BMI greater than 50. This comes to us from the Mayo Clinic in Rochester, Minnesota. This was a retrospective review of 329 patients who had type 2 diabetes who either underwent a Roux-en-Y gastric bypass, 2/3 of them, or a surgical sleeve gastrectomy, about 1/3 of them. The mean follow-up was about 6 years. Type 2 diabetes remission was seen in about half of them in this long-term follow-up. There were significant improvements in hemoglobin A1C, fasting blood glucose, diabetes, and of course, weight loss, and all were statistically significant. The type of surgery did not seem to make any difference. Both groups really benefited from this. So the take-home point of this particular study is that patients who have a high BMI and the metabolic syndrome, whether they undergo Roux-en-Y gastric bypass or they undergo sleeve gastrectomy, they should expect to see long-term durable positive impact on their diabetes, as well as weight loss, of course, and all the metrics for blood glucose hemodynamics. So this is an important study and helps us in counseling patients appropriately when they present for selection for these type of surgeries in the appropriate clinical context. The next paper in the surgical realm is this particular paper from the University of Padua in Italy, which is Antireflux Surgery's Lifespan, 20 years after laparoscopic fundoplication. This is a prospective study of about 137 patients who underwent laparoscopic fundoplication for the management of gastroesophageal reflux disease or a large hiatal hernia, about 30 of them. The median follow-up in this study was 22 years, amongst the longest I've seen in recent years for any study. A very small percentage of patients underwent revision surgery, which speaks to the skill set and careful selection of the patient cohort. Only about 9 patients out of 137 had repeat surgeries. Positive outcomes, on the other hand, were seen in the vast majority of patients with reflux at 84%, and still 2/3 of patients with hiatal hernia had positive outcomes over the long term. The failure-free survival was much more for gastroesophageal reflux cohort as expected compared to the hiatal hernia cohort. But patient satisfaction after 2 decades was almost 90% for reflux and almost 90% also for hiatal hernia, which is quite a significant milestone. So the take-home point from this study is that laparoscopic fundoplication is quite durable with success rates approaching 90%, even after 2 decades after the surgical intervention. This is quite an important data point for us to discuss with patients when they present with a question around surgery for these indications. Although, as we know well, in the era of PPI therapy, surgical indications for these are definitely reduced compared to 20 years ago. Now, the next paper in this group is related to another very important clinical entity, that is acute pancreatitis, and the question of pancreatic cancer in those patients who present with acute pancreatitis. Our previous work in this realm, published a couple of years ago, has suggested that about 3% of patients who come to the hospital with acute pancreatitis may harbor pancreatic malignancy, which can be picked up if we do a diligent follow-up with cross-sectional imaging and EUS. But this paper here talks about acute pancreatitis and the modeling of risk in terms of prediction for early cancer. This study was conducted at the University of Pennsylvania and basically speaks to a clinical prediction model to assess the risk of pancreatic cancer after acute pancreatitis diagnosis. So as we know, the risk for pancreatic cancer is highest within 2 years of the initial presentation of acute pancreatitis, especially if the etiology of that pancreatitis was unclear. In this clinical prediction model, as shown on this particular slide, a variety of demographic and clinical criteria were used, all of which are easily accessible to us in GI as well as in primary care to calculate the modeling risk. A large number of patients were used to apply this model to, specifically 51,613 patients. The mean age was 62%, and the overwhelming majority were male and half were Caucasian. Using this clinical prediction model, a 2-year incidence of pancreatic ductal adenocarcinoma was calculated to be at the 1.6% for an absolute number of 800 cases. Nearly 50% were discovered after 3 months, and there was a positive association with pancreatic cystic disease in these patients, which makes sense in terms of their pre-neoplastic potential. So the take-home point from this study is that readily available demographic and clinical criteria may be useful in helping us predict diagnosing early pancreatic cancer in a subset of patients who present with acute pancreatitis, and in my opinion, particularly those who present with pancreatitis that we cannot explain the etiology of. Now, the next paper we have here refers to a very common problem, which is H. pylori infection. Now, this is a almost endemic problem in the Far East and in the Third World, but also an increasing problem in the United States. This particular study comes to us from Taiwan and is looking at different treatment strategies for H. pylori infection. Now, in Taiwan and in the Far East, it has been proposed that high acid content in the food might be interfering with efficacy rates, as well as the consideration for antibiotic resistance may be an issue as well. So that's kind of in the background of this paper. So this paper is titled Enhanced Efficacy of Combined Bismuth and High-Dose Dual Therapy versus High-Dose Dual Therapy alone versus Quadruple Therapy for first-line treatment of H. pylori eradication. This was an interim report from a large multi-center randomized controlled trial and included 436 patients with H. pylori infection. Each patient had had biopsies with H. pylori cultures, and then they were randomized to one of 3 regimens as listed here. So they either got high-dose dual therapy, or they got bismuth along with high-dose dual therapy, so triple therapy, or they got the amoxicillin-based bismuth and quadruple therapy regimen. Breath tests were used to check for eradication at the end of the treatment period. In terms of the results from this study, it's very clear that the bismuth-based regimen, which is listed here in the middle column, had the highest treatment efficacy rates and moderate adverse event rates when compared to the other 2 arms. The reduced eradication in the dual therapy arm was seen probably due to increased acid food intake, and the reduced eradication in the quadruple therapy was likely associated with antibiotic resistance and also with poor compliance, which is understandable when you have more medications to take compared to the group that has fewer medications to take. So the take-home point from this particular study was that the addition of bismuth might be the silver bullet when you add that to the dual therapy regimen, and might carry the day in difficult cases of H. pylori infection. So more to come on this, and certainly of relevance to us here as we tackle more and more cases of H. pylori infection stateside. And last but not the least, GI and primary care discussions can never be complete without a discussion on colorectal cancer screening. Now, as the Nordic trial has shown us, it's not the issue with the screening modality, but more about patients' acceptance of screening, particularly invasive screening. So this paper here looks at different strategies and tries to figure out which strategy would be most attractive to bring more people in for screening. So this is a large randomized controlled trial with good distribution of patient population, with approximately half female, half Caucasian, and a mean age around 48 years. 20,000 plus patients. So one of 4 screening strategies was used. Either patients were invited for a FIT test, or they were invited to have a colonoscopy, or they were invited to choose between a FIT test and a colonoscopy. And the final group was basically not invited, but they were mailed a FIT test kit as an outreach mechanism. Invitations were sent via electronic patient portals, which are very common nowadays, as well as via the United States Postal Service. Text message reminders were sent a couple of weeks later. The primary outcome of this study was to look at any colorectal cancer completion rate at 26 weeks. The results of this study were quite interesting. Screening completion rates were relatively low at 18%, but it was interesting to note that the highest screening rates were seen with those who had the FIT test mailed to them, and each of the other three groups that had only invitations sent to them had relatively lower screening compliance rates. The lowest participation was in the colonoscopy invitation group, I suspect due to the invasive nature of the procedure and the patient's perception of that. When patients were offered a choice, they were more likely to be compliant with screening. And in the end, more patients chose colonoscopy as their screening test of choice compared to FIT testing. So the take-home point from this study is that sending directly test kits as an outreach might be more effective than simply inviting subjects to be screened. And then from those who do respond to be screened, more patients would choose colonoscopy compared to the FIT test. So with that, I come to the end of this video capsule summary for the best of GI for primary care from DDW 2023. We covered a variety of topics ranging from pancreatitis to H. pylori to colon cancer screening and a couple of GI surgical interventions with long-term outcomes that are very favorable. I hope you will find this information useful in the care of your patients, and I hope to see you next time with yet another edition of the best of GI for primary care in collaboration with WebMD and Medscape. Thank you very much.